Hello everyone, I'm Dr. Saurabh Dixit and welcome to my channel. So as promised, I am here back with one more video, and today I have brought a very simple but special topic, and the topic is aortic aneurysms. As you see that the exams are around the corner and aortic aneurysms have been a very important topic. Always you get a lot of questions from aortic aneurysm. So before we start with this concept of aortic aneurysm, I would just try to concise all these things in maybe 10-15 minutes. But before that, I will try to explain you what is criteria of aneurysm. So when do you call it aneurysm? So this is what is very important to understand, that there should be a dilatation beyond the limit when you will call it as aneurysm. So the most important thing that you need to understand here is dilatation of artery. So dilatation of artery with increase in original diameter. So with increase in original diameter by more than 50%. So if there is dilatation at any point and it is more than 50%, then only you will call it aneurysm. Now when you talk about aneurysms, aneurysms are of two types. What are the two types of aneurysms? One is a true aneurysm and one is a pseudo aneurysm. Now what is the difference between true aneurysm versus pseudo aneurysm? Same as it is versus a true diverticulum versus pseudo diverticulum. Now what is true aneurysm? All layers of artery, they are involved. So all layers of artery are involved, so the dilatation is complete. Now when you talk about pseudo, it is not all the layers, not all layers involved. What do you mean by not all layers involved? Now if suppose there is an accumulation of blood in between the intima and the media, or media and the adventitia, that is what is known as a pseudo aneurysm. So basically trauma, infections, Marfan's, the very common cause for pseudo aneurysm. But let us try to understand. Aneurysm per se is a very big topic, but I will try to concise it. So when you talk about the aneurysms, now the most common large vessel aneurysm and most common aneurysm, there are two important questions. So most common aneurysm of your body, yes, you are guessing it right, it's Berry's aneurysm. So it's Berry's aneurysm. But most common large vessel aneurysm is aortic aneurysm. So when we talk about aortic aneurysm, now we need to understand that aorta is also very long. So what part of aorta, if involved, will say what category of aneurysm. So aortic aneurysm is again of three basic types. Now you will say what, I have heard of two types, but sir, three basic types? Yeah. So one is involving the ascending aorta, so that is what is known as, or you can say one is involving the thoracic part of the aorta, so you can say thoracic aortic aneurysm. So we have thoracic aortic aneurysm, I would use the term AA for this. Then we have something which is known as abdominal aortic aneurysm. So we have thoracic aortic aneurysm and abdominal aortic aneurysm. Then one more important thing is there is a category of aneurysm which starts at the level of thoracic aorta, goes up to the what? Abdominal aorta. So that is what is known as the thoraco-abdominal aneurysm. So thoraco-abdominal aneurysm, aortic aneurysm, abdominal aortic aneurysm and thoracic. Now let us see, thoracic also is further subdivided into. So if we talk about the types of thoracic, it is first is the ascending aortic. So the ascending thoracic aortic aneurysm, this is one thing. Then we have the second is the arch thoracic aortic aneurysm. The third thing that you need to understand is it could be involving the descending thoracic aorta. So descending thoracic aortic aneurysm. Amongst the thoracic aorta, or you can say thoracic part of the aneurysms, it is the most common thoracic aortic aneurysm. Overall, which is most common? It is abdominal. So overall, if you talk about overall, the most common aneurysm is the abdominal aortic aneurysm when we talk about the aortic aneurysms. Now descending thoracic aorta, is further of three types. It is type A, type B and type C. Now what is type A, what is type B and what is type C? Now this is again very important. Now type A is, if you talk about the descending thoracic aorta, how do we see this? So try to understand this basic diagram of, so this is the diaphragm. So we can say this is the diaphragm, and above the diaphragm it is the thoracic aorta. Now when will you call it to be a descending thoracic aorta? It is after the origin of left subclavian artery that you will call the segment of thoracic aorta as descending. So the type A is from the left subclavian artery up to the level of sixth intercostal space. This is what is type A. So what is type A? From the left, so origin, if you talk about from the left subclavian artery up to the level of sixth intercostal space. Now this is what is very important. Now what is type B? This is again you have to understand. I will show you an image also. From the level of sixth intercostal space. So aneurysm starting at the level of sixth intercostal space, extending up to the 12th intercostal space. Now you will say, sir, what is 12th intercostal space? Because we don't have the 13th rib. So it's the space between the diaphragm and the 12th posterior rib. So that space hypothetically is known as 12th intercostal space. Basically this you can say up to the diaphragm, or from the 6th to the 12th rib also, that is justified. And then amongst them, what is a type C? The type C is a type which starts at the level of left subclavian artery and goes right up to the level of 12th intercostal space, or you can say the diaphragm. So this is from the 6th rib, from the 6th intercostal space up to the level of diaphragm, and this is from the left subclavian artery up to the level of diaphragm. So amongst them it is the type C which is the longest. So diaphragm you say, the 12th rib you say, the 12th intercostal space you say. Next is, let us talk about the abdominal thoracic aorta, abdominal aorta. So when we talk about the abdominal aorta, what are the types? So it could be infrarenal. What do you mean by infrarenal? That means the abdominal aortic aneurysm segment, it is below the level of the origin of, you can say, renal artery. So infrarenal AAA, do you know this is the most common type overall? So overall, if someone asks what is the most common type, it is the infrarenal. That is the aortic aneurysmal segment is below the renal artery level. The second is, it could be involving, so juxtarenal AAA. So it could be juxtarenal AAA. And the third variety, it could be suprarenal AAA. Now do you know that juxtarenal and suprarenal AAA, they are uncommon. Now why they are uncommon? Because they are frequently seen in females. An aortic aneurysm, by exception, gender predisposition, it is lesser in terms of incidence in female. So females, diabetics and the Negroes. So why the aneurysm is lesser in diabetics? Because of the stiffer wall. Female, there is a gender based predisposition that aneurysms are many times often seen in males. And then Negroes also, there is a, you can say their intima is more strengthier in comparison to the whites. This is what is the reason. So females, they are actually lesser in incidence, but one irony fact is the aneurysms occur incidence wise lesser in, or they're rare in females, but if they occur, they have a higher chance of what? Rupture. That is what is again because of the estrogen. Anyways, the third category is the thoraco-abdominal aneurysm. So let us try to understand what is the concept of thoraco-abdominal aneurysm. So when you talk about thoraco-abdominal aortic aneurysm. Now what is the challenge here that you get to see thoraco-abdominal aortic aneurysm? The answer is, it extends from thoracic aorta and goes right up to the, you can say, abdominal aorta. So we should be having the further bifurcations of this. Yes, exactly. So there is a classification that we have for this, and the name of that classification is modified Crawford classification. So what type of classification is this? Modified Crawford classification. So when we talk about modified Crawford classification, what are the things that you need to remember? They are further of 5 types. So let us try to understand. I will be more pictorial in this. So if you see, this is aorta. Now this could be taken as a level of diaphragm, and since the renal artery play a very important benchmark, so let us see this to be the level of renal artery. So let us take this to be renal artery level. Now one more thing that is very important answer is left subclavian artery. So after the left subclavian artery, the descending aorta starts. So thoraco-abdominal aneurysms, they are typically seen extending from descending part of the aorta, thoracic aorta basically, up to the abdominal aorta to variable levels. So what are the levels that we have? The type 1 extends from the, you can say the origin is just distal to the origin of left subclavian. So from the level of left subclavian, let us take, and it goes right up to the level of what, students? Renal artery. So the type 1 starts or begins at the level of left subclavian, goes up to the level of renal artery. Then we have type 2. So type 2 is actually extending throughout the length of aorta up to the bifurcation from the level of left subclavian. So from the level of left subclavian, this goes right up to the level of what, students? The bifurcation of aorta. So this is what is bifurcation of aorta. So you can see that this should be the longest type. Indeed, you are right. Yes, this is the longest type. The third variety is a variety which starts at the level of 6th intercostal space and goes right up to the level of left, you can say right up to the level of bifurcation. So 2 and 3, they have same termination, and 1 and 2, they have same origin. And then, students, we have the type 4th, that is starting at the level of 12th rib and going right up to the level of bifurcation. So this is type 4. Now you will say, sir, okay, type 1 is there, type 2 is there, type 4 is there, then why you have said type 5? The conventional Crawford had only 4. Now we have one more, that is the type 5. And what is type 5, students? You have to understand that from the level of 6th intercostal space up to the level of renal artery, now this is what is the type 5. So this is what is very simple to understand. 2, 3, 4, they have same termination, 2 being the longest, 1 and 2 have the same origin. So this is what is modified Crawford. Next is, how do you evaluate these patients and how do you manage? It's very simple to understand. So when you talk about the management, understand the investigation of choice is the CT angiography. So you need to undergo CT angio. Why and what do you need? Answer is, you need the aortic aneurysm diameter. So aortic aneurysm diameter, this is the most important factor to decide what should be the management. Now what is the classical treatment that we have? So this is very simple. I'll try to summarize it. Usually in class I teach this topic for a very long time, so for that you have to subscribe to my lectures, but right now I want to teach it in a concise way. So when we talk about treatment, there are two things that we have right now. Earlier we were not having anything other than surgery or observation. So either you can go for surgery or you can go for EVER. Now what is EVER, students? EVER stands for endovascular aneurysmal repair. So endovascular aneurysmal repair, that we will see, will cover up in detail in some different video, but right now it's very important for you to understand the concept of EVER and surgery. I just brush up this concept. So when you are talking about surgery, there are two important things. I'm not interested about what we do. The most important thing is, what is the inclusion criteria? Which patient would you consider safe for the surgery? The answer is, what is the fear that is there? Answer is, it is fear of rupture. Now for that you need to be cautious about the diameter. So cross-sectional diameter, this is what is very important. So if the cross-sectional diameter is more than equal to 5.5 centimeter, this is one thing, or students, or more than 4 to 4.5 centimeter in case of female. So generally I have told that females are protected, but in females the risk of rupture is very high. So females or Marfans. Why Marfan is included in this? Because in Marfans It's a collagen vascular disorder where the medial degeneration actually predisposes a quick rupture. Third is increase in diameter rate is again very important. So increase in diameter by more than equal to 1 centimeter per year, or students, or by more than equal to 5 mm by 6 months. So within 6 months, if it is increasing at a rate of more than 5 mm, that is again very important. So these are certain things that you need to keep in mind. There are more subdivisions. Whenever I teach super specialty students, I tell that okay, the basic consensus is more than 5.5. But if you talk especially of the thoracic aortic aneurysms, so for ascending aortic as well as arch aortic, if the diameter is more than 5, then also you can go for the repair. That is what is. Now, what is the second concept? What surgery do we do? The surgery, when we talk about, we go for resection. We go for resection of aneurysmal segment. So resection of aneurysm, and along with that, we go for a Dacron graft repair. So we go for resection along with Dacron graft repair. Now these are some very simple and important things that we need to understand. I'll take you to the image and you can see all the different Crawfords in front of you. This is Crawford 1, 2, 3, 4, 5. You can get this in exam. It's a hot favorite topic, and this is the descending aortic classification. So I told you from left subclavian to 6, from 6 it is up to the diaphragm and then complete length. So I will also show you what is the classical management. So the classical incision that we make is a thoraco-abdominal. Thoraco-abdominal, we have this classical incision, and then the next task is you need to just expose the aorta, cut open the adventitia. Now this is what you're doing, cutting open of the adventitia. Now when you are cutting opening it, there are a lot of lumbar vessels which are getting collaterals out of the aorta. So you need to close these vessels also, otherwise there will be a backflow via collaterals. And then the next is you need to take the graft, Dacron graft, and you need to go for a suturing. Now the suture of choice here is Prolene. You know, Prolene is the suture of choice for vascular surgery, and this is how you can modify the graft according to the segment which is involved. So this is what is very important, and then you can close off the adventitia. So this is how you manage the things. Now I will not go in much depth, but definitely I will talk about the concept of EVER. I'll make you leave, you can say, bit inquisitive about EVER, but definitely I will tell you what is EVER all about. So there was an era when there was no substitute other than surgery. Then came an era of stents. So now stents revolutionized the things, and now most of the patients who are planning for surgery, they try to delay the surgery by using a lot of stents. So EVER is again the very same concept. Now what is the concept? Why you are worried? The answer is you are worried because it could rupture. So placement, so what is EVER? It is nothing but placement of impermeable stent across aneurysmal segment. So when you talk about placement of a stent which is impermeable, what is the aim? What aim are you going to get? So if you place an impermeable stent, this stent is going to cut off blood entry into the aneurysmal sac. Now you will say, sir, how is this possible? I'll just show you the concept, brief concept. So even if the patient is not fitting into that criteria of aneurysmal repair, you can take a stent, and you can just place it across the aneurysm. So patients who are not fit for surgery, they are the ideal candidates. The patients who are not filling into this category of, you can say, diameter, they are also. And this stent has barbs, they will fix into the thick wall of the aorta. So now you can see the blood which is trying to enter into the stent is passed into the distal segment. No blood is going to enter. So the aneurysmal sac is not going to expand. Unfortunately, even if it ruptures also, there will be no problem because the blood flow to the distal part is continued. So there are a lot of complications of EVER which are known as endoleaks, where the blood manages to enter, maybe because of porous graft fabric, maybe because of the loose fitting, maybe because of the backflow. So these are all endoleaks. We have 5 types of endoleaks, but about that in detail in some different lecture. One very important thing that you need to understand is, could it be used for juxta or could it be used for suprarenal? Theoretically it is. Why? Because you can use a fenestrated. Fenestrated stents are there. Market says that fenestrated stents are there. You can fenestrate and take out the limbs into the renal artery. But try to understand, the diameter of renal artery is far less than the diameter of aorta, and there's a high incidence of RAT. What is RAT? Renal artery thrombosis. So practically we don't do, but theoretically yes, it is possible. We do it in thoracic aortic aneurysm. That is what is known as TAVR. So dear students, I hope you enjoyed this small crisp video, and do comment in the comment section how you liked. Do share it with your friends. Try to learn, and just subscribe to my channel, and just tell other students also about these lectures. Thank you.